eager to get started. We have a lot of health and social care rock stars in the audience and virtually, and I'm very happy you're here, and I'm very pleased to introduce today's lecturers. Both of our lecturers are extraordinarily distinguished graduates of the University of Chicago, Robin Golden of the Crown Family School and Bonnie Ewald of the Harris School. Their titles speak a great deal to their enormous distinction. Robin is Chairperson, Department of Social Work, AVP, Social Work and Community Health, Assistant Professor of Medicine, Nursing and Psychiatry. Bonnie is Assistant Professor of Medicine, Nursing and Psychiatry. They're both at Rush University. But rather than discussing their titles and achievements today, I would like to briefly describe what they're doing, in part because their mission aligns so closely with the mission of the Center for Health Administration Studies. Robin and Bonnie, in collaboration with other colleagues, launched the Center for Health and Social Care Integration, dedicated to 5 goals: social work practice innovation, research and evaluation, policy development and advocacy, training and education, and communication about health and social integration. To advance this work, they've engaged a distinguished national group of social work practitioners, policymakers, researchers, the Coalition for Social Work and Health. They've convened this group to engage in and give visibility to the work that they're doing. Now, much of this work, I should note, has been inspired in part by many things, but in part by a National Academy panel that Robin worked on and helped to organize, she participated in, that resulted in a National Academy of Science consensus report in 2019. Just a few words about the fundamental aspirations and goals of the center. The center really has emerged in the recognition of 3 things. The recognition that social risk factors, often referred to as social determinants of health, are deeply linked to health and well-being. 2, that expanded access to social care has a demonstrated positive impact on health outcomes. And 3, that social workers are specialists and experts in providing social care. It's no exaggeration to say that their work is having a demonstrable impact on the organization and financing of social work services and integration of health and social care. And I am delighted today that they will speak to us on paying for social care, investing in what matters. Please welcome them.
Thank you, as I still refer to you as Dean Jean. Thank you so much. And thank you, Keith, and thank you, Chaz, for having Bonnie and I back to campus. We're thrilled. The day turned out to be a nice one. So I want to just set us a little, and Jean, thank you for that introduction. But I want to talk a little bit about the imperative. We are thrilled to have the opportunity to talk about social care and investing in social care. More than 60 million Americans experience devastating 1-2 punches to their health. They have inadequate access to basic human care, healthcare, while also enduring the effects of discrimination, poverty, and dangerous environments that accelerate higher rates of illness. This came from the grand challenges, which Jean and Keith and I just spoke about, the grand challenges for social work. We have quite the imperative in front of us. We have the aging baby boomers, increasing rates of chronic conditions across ages, and many social and system factors that make it hard to meet people's needs and improve health. Health inequities persist. People experiencing inadequate access to basic care and resources while also experiencing systemic racism play out through discrimination, poverty, and dangerous environments that accelerate illness. The range of circumstances that people face and that influence their health have been shaped by a pretty brutal history. This history is baked into our current laws and institutions, and we need to address this reality head on if we want to change it. So, when the United States is compared against peer countries like France and Canada, it does not come out well. It comes out the very worst in terms of how we're performing in terms of health outcomes. On the top of this, you can see a number of countries with their own column, with the US in the right-hand column. Then you see multiple rows, different types of measures, quality, access, efficiency, equity, and healthy lives. And you can see very clearly that we are the worst. This came from a Commonwealth Fund report, which looks at how the United States stacks up against other countries on things like access to physicians, quality of care. It pulls from 3 separate surveys, which included not only consumers of sicker folks and who are healthy folks, but also providers. And basically it captures the experience of the medical system from the people who use it a lot, which is important to that we're always listening to our consumers and the physicians treating them, and still things don't look so hot, as you can see. Well, maybe this is connected to why things don't look so hot and maybe correlated to our low outcomes, that the US spends more on more medical traditional care and less on social care than any other countries. Social care, as we're defining, are the services that address health-related social risk factors and social needs into clinical practice. In 2019, the US spent 16.7% of our GDP on healthcare and 15.6% on social care. It's kind of the blue versus the green, compared with 10.7% on healthcare and 19.8% on social care in comparable countries. As you can see, I'm sorry, that's the blue. So we are spending more on more medical care, less on social care than anybody. Yet our analysis reinforces that our life expectancy seems to be shorter than most of all those other countries. So again, it really reinforces where are we with social care and why this is such an important discussion today. And such an important, Chaz was so instrumental in some of this work with us early on, so we're so excited to be partnering in this way. As social workers have recognized, and healthcare in general is increasingly acknowledging, much of what shapes our health is outside the realm of clinical or traditional medical care. Defined by the World Health Organization in 2017 as the conditions in which social determinants are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. SDOH, as we call them, are inextricably linked to access, delivery, and outcomes of healthcare. This graphic, based on nationwide community health data, county health data, is a model out of University of Wisconsin, shows that just how much social determinants impact the outcomes of care, with social and economic factors, the physical environment, and health behaviors estimated to impact 80% of an individual's health outcomes. These are all very intertwined. And what's so critical about this is that the bottom line is health is more than the absence of disease. And I think this really reinforces that. And this has been, if you will, a paradigm shift. For some of us who've been involved in looking at the person and their environment, which most of us who are social work related have done for years, this is nothing new, but it seems to be new in a lot of other arenas, which is exciting, a little frustrating sometimes because social work doesn't quite get acknowledged as having this history, but we're trying to bring that back to the fore. But the other folks kind of feel like they've discovered it in a new way. Physicians, nurses, not to bash our interprofessional colleagues by any way, shape, or form, but it's, sometimes it's hard not to say everything new is, been here or old again. So everything old is new again, I guess. So just to talk about some other factors, social determinants of health are not only intertwined with outcomes, at the community level, but when individuals report them as specific concerns within the context of the healthcare interaction, we see these individual needs also correlated with adverse health outcomes. There's plenty of evidence around that the importance of these health-related social needs, you all know this already again, but not everyone does, that we know that psychosocial challenges such as social isolation can increase stress and displace the focus and energy from attending to medical conditions. Adherence to medical care may become secondary to needs perceived as more urgent for survival, such as keeping heat on in the winter by paying utilities. On top of that, the literature shows that one's socioeconomic status and physical environment, such as unsafe housing, inadequate public transportation, can lead to higher use of emergency departments and other acute care, and to worse outcomes in terms of chronic conditions and life expectancy. I've been on emails all weekend about the fact that our asylees, we're doing a lot of work at Rush with our asylee population, and I don't know if you saw, but the police departments are full and there's nowhere for a lot of people to go. And of course, they are being sent to the emergency rooms as shelter, which is very complicated in terms of, is that the best use of an emergency room's resource? But what do people do and where do people go? And believe it or not, it's still warm out. So what's going to happen in a few weeks? We also know that the impact of these factors, such as access to employment and safe housing, accumulate influence health outcomes over a lifespan, more so than genetics do, resulting in inequitable outcomes in health. The unfair and avoidable differences in health status that are so prevalent in our city and our country. So it's hard to talk about social care without talking about health equity. Something we look at a lot is what we call the death gap. And we look at a map that goes from, in Chicago, not everyone on the Zoom is probably from Chicago, but we look at life expectancy that goes from downtown Chicago all the way to Oak Park. And it really reduces by, believe it or not, 12 years when we get from West Garfield Park from downtown, 85 to 60, 73 now, it went up 12 years. Anyway, and then it goes back up to 85 when we hit Oak Park. No surprise. For those of you who are on the phone, that's our first wealthier suburb to the west. So, social determinants of health have taken center stage in recent health policy discussions because of the growing focus on global payment, accountable care organizations, and other initiatives focused on improving population health. Our payers are noticing our healthcare costs are high, the outcomes are poor, so they've been wise enough to think, well, maybe it's social circumstances, social risk factors. So healthcare providers are increasingly being asked to measure impact in terms of health outcomes of the populations they serve. Given that medical care influences a relatively small portion of overall health, as I just showed you, these value-based financing models that Bonnie will get into a little more face substantial challenges in equipping healthcare providers to achieve improvements in the population's health. The increasing recognition by health providers and policymakers of the importance of social determinants is promising. Acknowledging that health outcomes are heavily influenced by factors beyond the four walls of the hospital, beyond the four walls of the physician office, is a pretty exciting one. Yet, health and social care delivery systems are not currently collaboratively addressing health-related social needs at scale. Why? Well, maybe some of us feel like part of it is that there hasn't been an absolute clear financial incentive due to the difficulty in quantifying the return on investment with this kind of spending. So we can talk about that a little more in the Q&A, but I left you with a little provocative piece there. Research is increasingly showing that not only do health-related social needs influence outcomes, but also that when we invest in activities to address those needs and to integrate care, we do see payoffs in terms of improvements in outcomes and in cost prevention and reduction. A study you may have seen before by Laura Taylor and colleagues review findings describing 39 articles regarding the health and financial impact of investments in social services or integrated models. Of these, 82% reported some significant positive effects on either health outcomes or healthcare costs or both. The literature indicated that most positive impacts on health improvement in healthcare spending reductions were evident in interventions relating to housing support, income support, food insecurity, and care coordination. So what I say very often, it's not enough for us to just screen for social determinants of health, but how are we going to address the identified needs? One cannot go with the other. Otherwise, we're setting people up for, again, falling through the cracks and not addressing their needs if we're screening and saying, you have this issue, but we don't have a way to help you with this issue. So it has to go hand in glove with hopefully some investment in the basic needs that people have, which are typically housing, transportation, food. As all of this work, it is critical that we be person-centered and try to understand people's own priorities overall and priorities in relation to accessing care. The National Age-Friendly Health Systems movement calls out the importance of being attentive to what matters most to patients. When we do that, we tend to see things like what Institute for Healthcare Improvement talks about, articulated recently. We want, what they hear from their patients in many surveys is, we want to be comfortable, we don't want to be in pain, we want to be close to family and to spend time on things that give us joy. We want the benefits of medical treatment, but we want to avoid the burdens if possible. And for those of us who work, oh, I'm sorry. Oh, I didn't know it was one of those. Fine. See, this is what happens when you work with younger people. Sorry, Debbie. Thanks, Bon. So what we see, and critically calls out that we truly take a person-centered approach to improve the quality of care while also improving the quality of life. Know that this person-centered approach of understanding what matters most to people paired with person-centered care with an interprofessional team is what is needed to achieve health equity, as we will hopefully know it someday. So I want to just let's look back as we think about how we can move forward to expand access to comprehensive and social care. In 2000, and I'm sure some of you in this room were involved in this work, Medicare pilots were a big deal. But during the 90s and the 2000s, CMS, Center for Medicare and Medicaid, launched a national case management payment methodology based on successful pilots with case management, with nurses calling assigned individuals to provide case management. As this quote summarizes, large firms quickly developed providing case management, but largely failed to deliver on quality and cost goals, and the program was essentially discontinued. Follow-up analysis showed that the programs that did succeed had one key element in common. First name, caring personal relationships in which the case manager was an advisory friend who got to know the person and made a personal connection. However, the majority of systems use models where the nurses called had no personal connection to the individual, and that the calls were often characterized by patients as harassment, which was opposite the goal. As IHI called out in 2011 in a white paper, these findings are critical for us to keep in mind as we think about social care, care coordination, interventions in general. It's incumbent upon us to center the patient's experience and priorities in order to be effective. So relationship matters. Nobody in this room is surprised by that. But how do we pay for relationship? It does pay off, but how do we invest in those kinds of relationships to make the difference that so many people are saying that is needed? Around the time we were part of a group with the New York Academy of Medicine, the Social Work Leadership Institute, to convene discussions about how to more effectively meet people's needs across the types of care. And particularly this was an aging focus back then, and many of us were very much focused on chronic conditions and functional limitations and looking at that in terms of care coordination. These discussions led us to creating the National Coalition on Care Coordination, which is active in DC to raise the profile of care coordination among policymakers. This happened at one time because this group first went in saying, let's get social work paid for, and had some pushback, particularly when they were meeting with CMS and other folks on the Hill, and people were saying, well, but what do social workers do? We don't care about the discipline. So we framed what we were doing as care coordination, which is not off, but what we were doing was social work and good social work. So we had to use that that name for a while, care coordination, and still do to some degree. And so kind of working on both tracks was the way we've kind of looked at this. One of the early reports we commissioned reviewed the needs around chronic care, identifying that this requires linkage between medical care and support services, as well as that interprofessional team members to address a person's unique needs. This laid, of course, the groundwork for social work. Then in 2011, and I think repeated again in 2017, Robert Wood Johnson Foundation surveyed 1,000 primary care physicians about the importance of interprofessional teams was reinforced through that study. It didn't go in with that notion, but what that study showed was that 4 in 5 reported that they did not feel confident in their capacity to meet their patients' social needs, which impedes their ability to provide quality care. They weren't aware of the social services available or complicated eligibility criteria they were confused by. So they were a little worried at times to even ask the questions what some of these needs were because they thought it would open a Pandora's box for them. 85% of primary care docs surveyed believe that unmet social needs, things like access to nutrition, transportation, housing, are leading directly to worse health for all Americans. So they believed it. And if they had the power to write prescriptions to address social needs, such prescriptions would represent approximately 1 out of every 7 prescriptions they write. And this was back in 2017. And that's huge when you think about it. This is part of the evolution and part of the excitement that we've been part of. In 2013, then, some of us were involved in a health affairs study that following that a group of us through the coalition, finding that we could lead to lower healthcare use and costs with social care interventions. And so we really started moving from screening to more interventions, and how do we invest in that need? And this study called for, or this article called for continuing to develop and refine models that are credible, replicable, and sustainable by researching the professional skills and knowledge, the activities, tasks, and services, and all combined with the patient risk factors that we can most impact with social support. So it was really calling for a deeper dive into what we've been trying to do. And then in 2019, we were involved with the National Academies report, as Jean mentioned, pretty exciting. We raised the flag really high to get the National Academies to look at a report just for social work. They had done one report on nursing, and we were excited by that report and thought, how can we have a report about social work? So we went down that path. And what ended up happening was in the 11th hour, they said, oh, the National Academy really doesn't do reports on discipline-specific kinds of things, even though they had finished the nursing report 6 years earlier, and we had heard a buzz that there was a new report to redo that nursing report already in the works. So here they booted social work out. They wanted to reframe it as social care. And, ultimately, we still got the attention, and maybe it was broadened to social care, but we tried to make the best of it, even though we were a bit frustrated. But the report was to help answer about who and when we should, as a national coalition who started this report and this work, who should be involved and when we should be involved as social care professionals. We secured funding from over 70 institutions, including UChicago, the Crown School, as well as Chaz, along with several local foundations. And this study, it was kind of amazing. It was the easiest fundraising I've ever been involved in because people really were committed to this. And I was lucky to be, lucky to be one of the 3 social workers on the panel. It was tough, though, too. There was a lot of challenges from the other disciplines on the committee, mostly physicians who were saying, you know, why social work? Why is social work part of social care? What have you done? Show us your evidence, that sort of thing. And we tried to accumulate the evidence and show, but it was still, you know, a tough sell at times. And so the bottom line is, how can services that address social needs be integrated into clinical care? That was the overall work that went on for 18 months, and I think some great outcomes did occur. Unfortunately, the report did come out right before COVID, so we took some of it on the road, but you know, we're still taking it on the road by talking about it here. So what the report talked about was that 2 helpful ways that the report helped the field by honing definitions. We talked about health-related social needs being within the context of a patient reporting a concern. We know, of course, that our social determinants of health that might be harmful to a patient's current or future health, even if they don't name it directly. The report suggested we call these social risk factors. The committee recognized that there were a number of ways that healthcare delivery systems can make a difference on these issues broadly, and define social care generally as activities that address social needs and/or social risk factors. We then outlined 5 complementary activities that facilitate the integration of social care into healthcare: awareness of these social risks and social needs, adjustment to clinical care, assistance to address needs, and alignment with community partners. And then last but not least, the final A that so many of us are connected to is advocacy, to minimize the social risk and increase social care resources. So we can get into that more later, but an example is transportation. So an example of awareness would be asking patients if they have a way to get to their appointments. Believe it or not, it's the major issue as to why people no-show, as they say. Also asking them about, can they get to the grocery store? Those sorts of things, of course, have an underlying impact on health. And alignment had to do with, can we reduce the need for in-person healthcare appointments by using other options such as telehealth appointments? This was, of course, before COVID, which now they become normative. Assistance had to do with, would we be providing transportation vouchers or coordinate rides so that patients can travel to healthcare appointments? Alignment would be investing in community ride sharing or time bank programs where volunteers could get together and help each other get to appointments or grocery store, you name it. And advocacy, of course, would be promoting policies that fundamentally change the transportation infrastructure within the community, or ensuring transportation benefits as available to uninsured individuals. What some of us liked about the 5 A's is it really integrates the micro and macro so well. So to use the 5 A's just a little more in depth, that the activities, and we turn to think about the resources needed and types of investment it takes to this work to be carried out. We need a workforce, an interprofessional one that ideally cross-sector, available to conduct screenings and to address needs and coordinate care. We need training and support. We need tech infrastructure such as adjustments. The interoperability aspect of this is critical. Our community-based organizations who could be involved in meeting some of these social needs and who are involved have no way to talk to the hospital, and vice versa. We need to invest in community partnership development, not just assuming that community-based organizations, social service agencies who can barely keep the lights on can deal with all this without giving them support to deal with it. And those are the people who are on the ground and really know what the residents of the community need most too. And we need to have the time and resources it takes to influence public perception and ultimately public policy around issues such as investment in healthcare services and workforce, investment in housing policies that help build intergenerational wealth, and the list could go on and on. So the report really did get into talking about who is the social care workforce, and it's nice to know that we did come out on top with larger font and everything, that social workers were recognized as specialists in providing social care. That was a battle, but we came out well. And then we included other other groups, community health workers, which is a growing group that Bonnie will talk about, navigators, nurses, home health aides, even lawyers came out very clearly. Our committee also recognizes there are significant systemic issues to address in order for this transformation to happen at a large scale in an effective, sustainable way, and that expanding healthcare beyond traditional medical settings will require health system administrators, practitioners, researchers, and policymakers to expand their emphasis on healthcare delivery to include social care, the services that address these risks. As many of us experience in our day-to-day, there are barriers to this. And part of it is our dominant medical model system. It's not designed around social care provision. We'll talk more about that. And that we need to embrace care models that have greater integration of both. And we need for those cross-sector partnerships. In terms of workforce concerns, as we see across healthcare industry, the recruitment and retention in social work and other roles doing this work is a concern, especially since so many of these positions are grant funded, and when the money goes away, the positions go away. So how do we do that? How do we make sure that everybody's staying in their swim lane, yet working as a team, reducing that competition, all of that? And then there's the financing challenges, which Bonnie will go into, and the answers around that. Just to end my part, in a recent Health Affairs, Laura Gottlieb, who's a friend of us from UCSF, who runs the Siren program there, she talked about the collective aspiration is that social care standards and incentives will help advance better health through more robust engagement by payers, redefining the scope of hospital services, delivery systems that are better equipped to support social care effectively, and more dollars to flow to CBOs and social services. This will absolutely enable population health change and what we should truly aspire to. And then in 2022, just to talk about a New England Journal of Medicine Catalyst report, a high percentage of clinicians and administrators in hospitals in healthcare settings say that patient health has been improved by SDOH, social determinant initiatives in their organizations. So on that note, Bonnie's going to tell us how that can happen. And we need these investments on how we can better make them. So thank you.
Hi, everyone. Wonderful to be here this afternoon. Thank you, Robin. Oh, we'll need that. All right. Thank you, Robin, for talking us through the imperative and our framework for the types of activities we're talking about trying to get investment in. I'd like to first start by just naming what are some of the typical funding sources for some of these diverse social care activities. We have grant funding, healthcare funding, governmental funding. So just to start at the top, governmental funding, this could include like SNAP funding, for instance, home delivered meals through the Older Americans Act. We have state funded initiatives like in Illinois' Choices for Care program that embeds care coordinators in hospitals to support folks as they go home from the hospital. Public health initiatives, we've seen a lot of public health dollars in the last few years be leveraged through a really, in an intentional way to not just do contact tracing, et cetera, but to help address social needs so people could isolate, et cetera, if they had COVID or were exposed. There's been federal and state funded demonstration projects. I'll talk about a few of the things on the Medicare and Medicaid innovation side, but we've had demonstration projects, like one we were involved